Dear colleagues, dear guests, dear friends, welcome to this political discussion on improving care for Alpha-1 patients. I'm honored to be able to virtually host this event, and I'm glad that Alpha-1 Global approached me with this request to mark in advance or in anticipation, if you will, of the 2021 European Alpha-1 Awareness Day. I want to congratulate Alpha-1 for what they are doing, because the conditions has low awareness, even among healthcare professionals. These events are needed, especially now when so many political healthcare topics are being discussed. For this reason, I'm delighted to be able to do it now. I remember last year, we were not able to commemorate this day. I also wanted to welcome and thank my esteemed colleague Marisa Matias for co-hosting this event. Today, we have gathered a number of stakeholders and patients, and we will speak about Alpha-1 in the context of upcoming policy revisions, and of course, not omitting the particular COVID-19 situation, a situation which is particularly affecting Alpha-1 patients. COVID-19 poses a public health risk to the EU population at large, but more particularly to vulnerable groups, and especially to patients suffering from rare diseases with pre-existing respiratory conditions, such as Alpha-1. Broadly speaking, we need to have European measures tackling rare diseases and particularly improving lives of vulnerable patients groups in times of pandemic. This was also highlighted by Commissioner Kyriakidis, who noted that we need to ensure that all rare disease patients in Europe have access to the right diagnosis and treatment they need, as especially in the first months of the pandemic, an estimated 84% of rare disease patients experienced some sort of disruption of their care. So today we are here to listen to you, listen to experts, and be able as politicians to keep Alpha-1 in political discussions and make sure that upcoming policy reflects the needs of patients. There is an upcoming revision of the Cross-Border Healthcare Directive, and it is timely now to consolidate our perspective and make certain your views are reflected in this process and ultimately improve care for Alpha-1 patients. I was reading the Alpha-1 policy recommendations and discussing with Alpha-1 representatives, and I'm eager to hear more about how the European reference networks can be improved in the future. The IRNs are fantastic instruments created by the EU, but it is also true that there are some shortcomings which can be addressed. I'm interested in hearing more about this form from Professor Chorostowska, I hope I say your name correctly, who is speaking today later on. These are my short welcoming remarks. Welcome to all. I'm looking forward to the discussion, and now I will pass the floor to Mrs. Matias. Marisa.
Thank you so much, Isabel, and thank you everyone from this initiative. It's really a pleasure being part of this, and it is also a pleasure to co-host with my dear colleague Isabel Wiseler-Lima. This is, as Isabel just said, this is a moment for us to listen to hear your demands, to know what should be our emphasis in terms of dealing with Alpha-1 disease and other rare diseases in the European Union, and especially because you are so acknowledged about all the situation, not only as patients but also as family members and as experts and researchers, and this is quite important for our action. In these initial words, I just want to say that it's really important that we discuss this in this moment, because, as you know, health is at the core of the European intervention, as it is research and innovation, and we cannot you cannot forget that it's crucial for us to have an approach, but an articulated approach and coherent approach on the rare diseases and on particular on Alpha-1. I know that you are launching a call for action. I want to reinforce that I fully support the call for action that you are trying to promote, because it's really important that we develop at the European level the European reference networks, as is important for us also to help and to define the legislations in order to improve diagnosis and to have as a key objective the access to treatment, and also, of course, to, as always, to have an holistic approach. I will come back in the end of the session. In any case, now I just want to listen from you, as my colleague Isabel said. And I want to tell you that the 25th of April is a wonderful date, because it's a very important day for the Portuguese people and for Portugal as a country. So I think it's really great that we can raise awareness concerning Alpha-1 at the same time that we celebrate democracy around Europe. So thank you so much. And I don't want to make a longer speech, so I'll pass the word to Jordan. Thank you so much.
Thank you very much, Ms. Matias, and a huge thank you to you and Ms. Wiseler-Lima for your continuous support and engagement with the patient community. Welcome to everyone. For those of you who don't know me, my name is Jordan Alexandrov, and I'm grateful for the opportunity to be able to moderate today's event. I'm an associate director at RPP Group. We are a Brussels-based healthcare consultancy, and we have had the chance to work and collaborate with Alpha-1 Global for the past several years. Please note that this event will be recorded, and Alpha-1 Global will make this available to other patients and the public who are not able to attend. Today, we are joined by patients, clinicians, academia, and industry representatives, and we have a number of presentations on our agenda. First, we'll hear from Alpha-1 Global, who will set the scene. Then we'll hear from Professor McElvaney, who will give an introduction about Alpha-1. After him, we'll welcome Professor Chorostowska-Wynimko, who will speak about Alpha-1 and the European Reference Network. Following her, there will be a presentation from Shane Fitch, who is an Alpha-1 parent, before hearing at the end the perspective of the European Commission and the upcoming revision of the Cross-Border Healthcare Directive. At the end of the event, there will be time for questions and answers. To be able to participate in this section, please use the chat function or the Q&A box, which you see in front of you. Type in the question you would like to be asked and to whom. And please make sure to state your name and your organization before tabling your question. Then I'll be able to ask your question to the panelists. As Ms. Wiseler-Lima and Ms. Matias underlined in their introductory remarks, today's event is about Alpha-1 patients and what is politically needed to improve care for this patient community. With the European Commission constantly looking into how to improve the lives of rare disease patients, today there is an opportunity to elaborate more on this and other issues where EU's coordinating role can have an added value for Alpha-1 patients. So our first presentation for today is from Randall, who is a Senior Director of Research Programs at the Alpha-1 Global Foundation. Randall will outline the priorities of the international Alpha-1 patient community and make concrete suggestions on particular considerations for Alpha-1 patients in the upcoming European policies. Randall, the floor is yours.
Thank you, Jordan. Thank you, Ms. Wiseler-Lima and Ms. Matias for hosting this event. We are honored that you've taken time out of your busy schedules to join us today. As Jordan mentioned, my name is Randall Plant. I'm the Alpha-1 Global Director for the Alpha-1 Foundation. Next. Alpha-1 Global is a program of the Alpha-1 Foundation. Alpha-1 Global's programmatic mission is to develop a collaborative global network of Alpha-1 patients, patient leaders, physicians, and researchers to increase awareness, detection, and access to care for alphas around the world. I'm pleased to say that we have representation from each of these stakeholders attending today's event, in addition to our government officials and industry partners. Alpha-1 Global's priorities include facilitating stakeholder collaboration, raising Alpha-1 awareness globally, and promoting early diagnosis and optimal access to care. Alpha-1 Antitrypsin Deficiency is an inherited condition that affects the lung or liver. Alpha-1 patients are found worldwide, with the prevalence in Europe affecting about 1 in 1,500 to 3,500 individuals. The burden of Alpha-1 can be significantly impacted by the delayed diagnosis and limited access to treatment. Early diagnosis is crucial for Alpha-1 patients, but it is also a main difficulty in managing the disease. Most patients will not be diagnosed until symptoms have begun, despite the low cost and effective means of diagnosis, a blood test. Misdiagnosis prevents and deters the appropriate referrals to Alpha-1 centers of excellence. For these reasons, it's imperative that we achieve a consolidated approach for patients, healthcare professionals, and government. Policies that facilitate sharing expertise and encouraging preventative measures, such as screening, will benefit all patients. Alpha-1 Global's priorities directly correlate to today's call to action. Our call to action was developed as an outcome from previous political discussions and building on the Alpha-1 European Expert Group policy recommendations published in 2017. It is timely to do a call to action now, given that associated policies will be revised soon, as we hope that the Alpha-1 patient perspective will be considered when these revisions are performed. The first call to action is regarding European reference networks. As we know, ERNs aim to have specialized healthcare professionals collaborate to provide guidance on rare disease diagnosis and treatment. This places ERNs in a position to address some of the most important challenges faced by Alpha-1 patients. It is therefore essential that ERNs function as efficiently as possible. In its special report, the European Court of Auditors concluded that European reference networks for rare diseases are an ambitious innovation, but their sustainability has not been demonstrated. Among other shortcomings, the ECA identified the absence of an effective system to assess ERN participants. In light of the upcoming revision to the Cross-Border Healthcare Directive, this call to action is that the European Commission should consider developing a project to generate minimum credentials for Alpha-1 centers of excellence. The second call to action relates to improving diagnosis. A lack of accurate and timely diagnosis is a major challenge for Alpha-1 patients due to a lack of awareness of the condition. Alpha-1 is excluded from systematic screening programs, even though it can be diagnosed through a simple blood test, as I mentioned earlier. Since Alpha-1 is an inherited condition, once one family member is diagnosed with Alpha-1, all family members should be tested for Alpha-1. However, family members may be hesitant to be tested because diagnosis triggers increased insurance premiums. The improving diagnosis call to action is that member states should consider developing an Alpha-1 diagnosis program as part of a rare disease plan. The European Commission should update the 2002 Cordis study and issue subsequent recommendation to member states. And finally, newborn screening for Alpha-1 should be considered, recognizing the importance of avoiding expensive, untreated disease progression and expensive organ transplantation. The third call to action is extremely important. It is access to treatment. Alpha-1 currently has no cure. However, the treatment for Alpha-1 is augmentation therapy, which aims to slow progression or prevent progression of lung disease. Despite this therapy success and proven cost effectiveness, it is reimbursed only in a few member states. That must change. Alphas need access to therapy. This call to action is member states should make augmentation therapy available and reimburse it for all patients. Member states should enact legislation that does not deter individuals from genetic testing by ensuring that non-symptomatic patients will not have higher insurance premiums. The final call to action is having a holistic approach. The improvement of care for Alpha-1 patients should include a holistic approach, taking into consideration environmental issues such as pollution, both indoor and outdoor, and the toxicity of chemicals in employment settings. It is important because Alpha-1 patients can develop worse symptoms in environments with air pollutants. We believe the European Commission should develop a comprehensive strategy on indoor air quality. EU member states should improve ambient air quality through effective implementation of the EU and World Health Organization developed air quality standards. Successful implementation of these call to action items requires broad support from various stakeholders, including EU institutions, national members, patients, and healthcare providers. We believe at Alpha-1 Global that together we can make a difference, enact these call to actions, and make lives better for alphas in Europe and around the world. In the US, during COVID, the Alpha-1 Foundation has been able to bring together various stakeholders to minimize the risk alphas have faced during the pandemic. COVID has given us the opportunity in the US to better serve alphas by advocating for expanded coverage from government programs and services. Alpha-1 patients get infusions on a weekly basis, and going to a doctor's office or hospital setting to receive treatment during COVID puts alphas at risk. The Alpha-1 Foundation was able to obtain emergency approval for patients on government programs to receive home infusions of the therapy. We were also able to expand government program telehealth coverage, again, minimizing the risk to alphas by not having to go to a doctor's office or hospital. There is a large appetite to continue and extend these government programs post-COVID. This is very important because half of the US population relies on government programs for healthcare assistance. These are two examples of how patient care can be improved through collaborations and partnerships between patients, patient organizations, healthcare providers, industry, and government. Sunday, April 25th is Alpha-1 EU Awareness Day. We hope you can join us in celebrating this day by using the hashtag Alpha-1 Awareness Day on your social media channels. We will share the banner and hashtag after the event so you can share it on your social media channels to help us celebrate this important day. Finally, thank you. Thank you to our hosts, Mrs. Wiseler-Lima and Ms. Matias, for endorsing and co-hosting this event. And we thank the attendees for joining us today. Thank you.
Thank you very much, Rando, for this insightful presentation. Indeed, very valid points on the European reference networks. As you say, this was highlighted in the Alpha-1 European expert recommendations, which were published in 2017, and at least at European level for the past couple of years, the functioning of the European reference networks, as well as the functioning of the Cross-Border Healthcare Directive, has been widely discussed. And I'm sure we'll hear more on the topic from Professor Chorostowska and later on from Mr. Dorazil from the European Commission. Our next speaker is Professor Gerry McElvaney from the University of Medicine and Health Sciences. Professor McElvaney will briefly explain what is Alpha-1 Antitrypsin Deficiency and what are its particularities. Professor McElvaney.
Thank you very much, Jordan. And again, I'm very grateful to the organizers for inviting me here today. My name is Gerry McElvaney. I'm Professor of Medicine in RCSI Medical School in Dublin, Ireland. Next slide, please. So Alpha-1 Antitrypsin Deficiency was discovered relatively recently, just under 60 years ago, in Malmö in Sweden. And two very astute doctors noted that some people who had a lack of a protein in their blood had a significantly increased risk for emphysema, even if they didn't smoke. And they characterized this protein, and they called it Alpha-1 antitrypsin. And they found that people with low serum levels of Alpha-1 antitrypsin were more prone to lung damage. And later, we found that it not only caused lung damage, it caused liver damage as well. Next slide, please. So basically, we have two diseases. We have a lung disease and we have a liver disease. Next slide, please. If we look at these two together, looking first at the liver disease, we have what we call a gain of function. So in the classic form of Alpha-1 antitrypsin deficiency, the mutant protein, which is called a Z or Z protein, gums up in the liver. It polymerizes in the liver and causes inflammation in the liver. But in addition to that, it fails to get out of the lung, out of the liver and into the lung to protect the lung. So in the liver, you have a gain of function where there's too much of the abnormal Alpha-1 antitrypsin causing inflammation, and in the lung, not enough of the normal Alpha-1 antitrypsin to protect the lung. So you get liver and lung disease. Next slide, please. So what does that mean? What's the worst that could happen? Next slide. Well, you get very severe lung disease. With severe Alpha-1 antitrypsin deficiency, you can get emphysema. So the body has major difficulty in getting oxygen from the air into the bloodstream. And this can lead to death and transplant. And in fact, Alpha-1 antitrypsin deficiency is one of the commonest causes of transplant worldwide. Next slide. You also can get liver disease. And this manifests itself sometimes as cirrhotic liver disease, cirrhosis, even if you don't drink that much. And there's a small but significantly increased risk for liver cancer. It can also manifest itself in children with jaundice at birth. And in a small percentage of these children, they require liver transplant in the first year of life. And finally, next slide, please. It can also manifest itself with a severe skin disease called paniculitis. This is a rare condition but can cause death. Next slide, please. So our job is to prevent all these. So to put this in context, Alpha-1 antitrypsin, next slide, please. Alpha-1 antitrypsin is a genetic disorder. The normal alpha-1 gene is the M gene. If you get an M from your father and an M from your mother, you're an MM. The classic deficiency forms of alpha-1 are the Z or Z gene or the S gene. So every person inherits 2 copies of a gene, one from their mother and one from their father. So let's look what happens when you have an MZ father and an MZ mother. Next slide, please. What you get are a 1 in 4 chance that each child will be a ZZ. That's the very severe form of deficiency. But a 1 in 2 chance that each child will be an MZ. Now, for many years, we thought the only problem would manifest itself in people who are ZZ, those who had the alpha-1 gene from both parents. But we now realize that even the MZs or the SZs have an increased risk. Next slide, please. So we did this study in Ireland in conjunction with a group in Harvard. And we reduced referral bias in a special way. And we studied over 51 Irish families and 250 people. Next slide, please. And we showed unequivocally, next slide, that people who are MZs who smoked had significantly increased risk for COPD or emphysema. In fact, their risk was 5 to 10 times greater than an MM individual who smoked. And an MZ individual who smoked a little would have the same lung disease as an MM individual, a healthy control individual who smoked a lot. So this is the first time we ever found that MZs, whom we had referred to as carriers in the past, had a significantly increased risk for COPD. But we also knew, and I think it's been referred to before, that we are grossly underestimating the number of MZs in the population and only picking up a small number. Next slide, please. Next slide, please. What about SZs? This is another form of alpha-1 antitrypsin deficiency. And again, working with our colleagues in Harvard, we looked at 44 Irish families and 166 people who participated in the study over 3 years. And we looked again at their breathing tests. Next slide, please. And we found that SZs have an increased risk for COPD, similar to MZs, but only if they smoke. So this is an important point. MZs and SZs who don't smoke have no increased risk for COPD or emphysema. Again, reiterating the need to stop people from smoking. And we find that people with alpha-1 antitrypsin deficiency who are told to have the problem and are told to stop smoking usually do. Next slide, please. So we showed in a follow-up registry that the SZs had a moderate deficiency, but if they smoke, they have an increased risk. Next slide, please. Next slide. Yeah. So in this slide, you can see these are people who didn't smoke. There's no difference between the SZs and their MM counterparts, their siblings. So people who don't smoke have no increased risk for lung disease. Next slide, please. But when we look at SZs who smoke, and they're in the orange line here, compared to the greens who are MMs who smoke, there's a significantly increased risk for SZs. So SZs who smoke have an increased risk for COPD. MZs who smoke have an increased risk. ZZs who smoke have a phenomenally increased risk if they smoke. But unfortunately, ZZs, even if they don't smoke, can get emphysema and COPD. Next slide, please. So here's the risk. A ZZ has severe deficiency, a significantly increased risk of lung disease, both in smokers and non-smokers, and an increased risk for liver disease. SZs, significantly increased risk of lung disease in smokers and an increased risk of liver disease, but no increased risk for lung disease in non-smokers or never smokers. MZs, significantly increased risk of lung disease in smokers, but not in never smokers, but an increased risk for liver disease. So over the last number of years, we have worked out who's at most risk. But the problem is we're not diagnosing people in sufficient numbers. Next slide, please. So here's what we think is a typical alpha-1. It's usually a male, usually in their 50s, an ex-smoker. They've smoked about 20 cigarettes a day for 20 years. Their lung function is down about 63% of what it should be. Their CAT scan shows emphysema, bronchiectasis. They have abnormal liver function tests. The liver ultrasound will show a fatty liver. And here's the kicker. They're diagnosed at age 45. And there's a big delay in diagnosis, as much as 9 years from the time they had symptoms. And it's reckoned in the US, it takes 5 doctors 7 years to make the diagnosis. Now that's what we think, but reality is somewhat different. Next slide, please. Because a typical Alpha-1 could be that child there who presents with jaundice at birth. About 10% of ZZs present with jaundice at birth. In the majority, it clears up, but a small percentage need liver transplant. Next slide, please. Or these individuals here, all presenting with liver or lung disease at different times in their lives. Next slide, please. So how common is Alpha-1 antitrypsin deficiency? We did a study in Ireland using a DNA database, and we found that in the Republic of Ireland alone, a small country of less than 5 million people, there's 171,000 MZs, about 2,000 ZZs, and about 10,000 SCs. Next slide, please. Next slide. And if we look to Ireland, both north and south, in the Republic and Northern Ireland, 250,000 MZs, 12,000 SCs, 3,000 ZZs. In fact, the carrier rate for the Z gene in Ireland is 1 in 25, which is very, very common. Something we had totally underestimated in the past. Next slide, please. So who do we test? How do we increase our ability to detect people with Alpha-1 antitrypsin deficiency? Well, the World Health Organization and the ATS and ERS produced these statements. And what they said was, next slide, please, that we should test certain groups. All people with COPD, next slide, please. All non-responsive asthmatics, next slide. All people with cryptogenic liver disease, next slide, please. And all patients with paniculitis. And all first-degree relatives of patients or carriers with Alpha-1 deficiency. So we should test these people irrespective of what else they have. And so that led us in Ireland to set up a targeted detection program. Next slide, please. And we set up a targeted detection program whereby if you had COPD or poorly responsive asthma, or if you had cryptogenic cirrhosis, or indeed if you're a first-degree relative of a person with Alpha-1 or had paniculitis, we would test you for Alpha-1 antitrypsin deficiency. And this is funded by our government. And we also set up a system whereby if your levels of Alpha-1 were low, we would test you for Alpha-1 antitrypsin deficiency. Next slide, please. And we've screened over 20,000 people to date. We receive approximately 150 samples per month. Next slide, please. And what we have found is most of our referrals are from people with COPD, but a significant number have liver disease, some have asthma, and some have reduced Alpha-1 antitrypsin levels, quite a number of a family history. So over 20,000. Next slide, please. What have we found? We've detected almost 4,000 MZs, nearly 400 ZZs, and around 400 SCs. So about 30% of the people we test have an abnormal gene. So this tells us an awful lot. This is the type of program, a targeted detection program, which would be very beneficial throughout Europe. Next slide, please. There's something else we've found. Not only do your parents give you their genes, they give you their smoking habits. If your parents are smokers, there's a significantly odds ratio of the children being smokers as well. Next slide, please. So it's a double whammy, a double hit. You have an increased genetic risk, and you have an increased social risk. Next slide, please. And it's not just a double hit. We've mentioned earlier about the problem with pollution, and we found that people, even with the MZ form of Alpha-1 who smoke, have increased risk if they're exposed to vapors, dusts, gases, or fumes, both inside and outside in their work. So again, it's a triple hit. Next slide, please. We haven't mentioned much about liver disease. We're still learning about the liver disease associated with Alpha-1, but we know if you've got a fatty liver, or if you drink a lot of alcohol, and you have Alpha-1 antitrypsin deficiency, MZ, SC, or ZZ, you're going to have an increased risk for liver disease. Next slide, please. Are there specific treatments? Randall has mentioned augmentation therapy. widely available in the US and some parts of Europe, but not all parts of Europe, including my own country. Licensed by the FDA in 1987. Next slide, please. And a rapid trial which was carried out in the US and in Europe in 2015 showed definitively that plasma purified alpha-1 antitrypsin can slow down progression of emphysema in people with severe deficiency of alpha-1. Next slide, please. And here's the data. You can see the blue line is people receiving plasma purified alpha-1 antitrypsin. That is alpha-1 purified from the bloods of individuals. And then the red line is people receiving placebo. And within 2 years, there's a 33% reduction of progression of emphysema in people receiving treatment. And then at the end of the 2 years, those who received placebo were placed on the therapy, and again, the rate of decline significantly decreased. Next slide, please. So that's one treatment. There are others, potential ones. There are oral elastase inhibitors, which can replace the alpha-1 antitrypsin in the lung and prevent the progression of lung disease. Next slide, please. And then there's specific therapies aimed at the liver, where we can knock out the Z gene in the liver. And then new therapies aimed at unfolding the alpha-1 antitrypsin in the liver, getting it out of the liver and into the lung, hitting both parts of the disease at one go. So there's lots of treatments on the horizon for alpha-1 antitrypsin deficiency. We just have to get our patients access to them. Next slide, please. So in conclusion, alpha-1 antitrypsin is the prototype COPD biomarker. It's easy to measure. The lower the level, the greater the risk. Next slide, please. You have to test for it, though. It's no use thinking about COPD and not testing for alpha-1. Next slide, please. What do we do if we get a diagnosis of alpha-1? We stop people smoking. We're very good at that. We look at their environment. Can we change that? Next slide, please. We screen their family and pick up people early before disease exerts a terrible influence on them. Next slide, please. We have genetic counseling. We tell people what the risks are for lung disease and liver disease based on our knowledge. Next slide. We rehab them in pulmonary rehab. Very important in people with COPD. Next slide, please. We assess their liver in addition to their lungs. We see what the risks are for liver disease. Have they got a second hit? Are they drinking too much? Are they overweight? That sort of thing. Can we intervene? Next slide, please. We get those patients to a specific designated specialist alpha-1 clinic. And we have set that up in Dublin, and others are following our example. And next slide, please. We get them involved in clinical trials, because these clinical trials are long-lasting, they take a long time, but if they're effective, we want our patients on them early, we want access to trials, and we want access to effective drugs, as Randall has mentioned. Next slide, please. I'd like to thank you very much for your attention. Gurmila Mahagov. I really appreciate the opportunity of talking to you here today, and hopefully we'll be able to answer any questions you might have in the question and answer session at the end. Thank you very much.
Thank you, Professor McElvaney. And in the meantime, I saw that Ms. Roberta Metsola from the European People's Party from Malta has joined us. Ms. Metsola, we are very glad to have you with us. And now I would like to give the floor to Professor Joanna Chorostowska-Wynimko, who is the lead of the Cross-Border Care Committee of the European Reference Network for Lung, the ERNLung. Professor Chorostowska is also the coordinator of the Central Eastern European Alpha-1 Network and a coordinator of the National Alpha-1 Antitrypsin Deficiency Registry. Professor Chorostowska-Wynimko.
Thank you very much. Thank you very much for this very kind invitation. I'm really happy and proud to be here with you. As a representative of healthcare professionals who work and help Alpha-1 patients, Professor McElvaney provided you with a very comprehensive overview of what Alpha-1 antitrypsin deficiency is. He also, I think, very nicely shown that we have the knowledge and expertise how to effectively provide the genetic diagnostic, the clinical diagnostic, and treatment to alphas in Europe. So now the question is how to make sure that the healthcare provision in Europe is equal in terms of the merit, the expertise, but also access to both diagnostic and treatment. And next slide, please. And that has been an issue in Europe for some time, and roughly at the same time when the rare diseases networks have been brought to life by European Union. European experts, Gerry and me included, have published the guidelines, the call for action. As you can see, we mentioned that in order to ensure that all Alpha-1 patients are cared for in a holistic way, we need support from European Union, but also we need support from national governments. We called for a coordinated EU policy to harmonize standards and benefit patients from differential expertise. And indeed, next slide, please. The networks of European reference centers provided that kind of expertise and excellence. So what is really important, in my opinion, in the idea of European reference networks, and I am very happy to work within the ERNLung network dedicated to rare diseases of respiratory tract, is that the networks are able and do share not only the professional expertise, the medical expertise, but we also are very dedicated to providing the proper medical expertise to patients. And importantly, I think it needs to be emphasized also to educate our colleagues and also help patients to educate the society about the rare diseases, and in this case about Alpha-1. Next slide, please. So as I mentioned, I'm part of the ERNLung steering committee, and within this network dedicated to the respiratory system, Alpha-1 Antitrypsin Deficiency core group is one of the distinct parts of this network. Next slide, please. So this picture represents the network, Alpha-1 network, and here comes the first issue I would like to address. I mentioned that what we need really is the network of specialized, dedicated centers that would be able to provide both expert diagnostic and treatment to the patients. The ERN structure includes, per definition, so-called core members or full members, so that the centers that are both fully qualified to serve as a highly specialized centers, but at the same time are endorsed by local governments. So as you might see, we here within the structure of Alpha-1 network, we have both full member, core members, but also affiliated partners. So those partners are actually the new category that we have to create, because those centers, although fully expert and able to provide highest expertise, for some reasons, sometimes administrative reasons, were not endorsed. And we very much wanted to include them into the network. And secondly, you also see the supporting partners. So those are centers that are not fully qualified as expert centers. But having said that, I think this is a very important message for the future. We should also open the networks for the centers who really intend or aim to become an expert, or have to gain some expertise in order to provide this service for the region, for the country. And therefore, in that aspect, definitely the definition of a network member should be a bit modified. Nevertheless, as you can see, we were able to build quite an impressive network within Europe, although there is definitely a need for the growth. They need to extend this network to some regions, to more countries. Next slide, please. And just very shortly, what we considered as the main aims of our core Alpha-1 group. First, of course, it was a growth. It was to really make sure that all the countries or major regions of Europe are being represented. And we did, therefore, this, let's say, new definition of supporting partners or contact point centers. And our priority definitely was not only Western European countries with a good history, impressive history of Alpha-1 research and activity, but also those countries within Europe that are relatively new to Alpha-1 field. Next slide, please. So growing of the group, but also providing the highly specialized healthcare for Alpha-1 patients in Europe. For that, of course, the cross-border clinical cooperation is absolutely fundamental. As you have seen from the map I provided, there are regions and countries in Europe where there is not a specialized care for Alpha-1 patients. Hence, the importance of cross-border clinical cooperation. Next slide, please. For that, ERNLung is actually ideal setting. This is the structure that has been, as I said, born in order to provide the expertise, trans-border expertise, and indeed, it's really, really helpful. So we have developed the online Exabo system. This is the expert advisory board. This is the online system, and it proved very efficient during the COVID times, that serves both healthcare professionals and, importantly, patients. This is the system that provides both education and information, and is shaped for both groups. Next slide, please. But also, we within the ERN networks, we use the clinical patient management system. This is a system defined more for a healthcare professional, for the specialized care, and it was designed to enable live discussions of clinical cases. And it really proved very efficient, but only within the network. So the unmet need, as I called it, is that CPMS is open only to those centers who are part of the network. Therefore, it allows us to communicate only within the centers that are part of ERNLung, whether we do believe that it would be very helpful to open it to the interested specialized respiratory, in this case, centers, who would be able to share and discuss with us the difficult clinical problems. Next slide, please. Also, we developed a defined algorithm for cross-border care. As you might imagine, this is quite a complicated problem involving not only clinical matters, but also legal matters and matters related to the local national regulations regarding the reimbursement of care. And also there is a certain specificity of Alpha-1 antitrypsin, which actually is helpful in this regard, that with this algorithm, we are able to help those countries, those centers that do not have access to diagnostics, to genetic diagnostics, because unfortunately this is a reality of number of countries within European Union. So we can at the first level provide them with help in terms of actually confirming the genetic diagnosis of Alpha-1, and then consequently, if necessary, also provide clinical expertise. And optimally, at the stage 3, we would love to also provide access to treatment. And I think this is the most difficult part. It has been addressed by previous speaker, and this is, I think, something for the future that definitely needs our action. Next slide, please. So yes, and next and next. So those are the bullet points I wanted to emphasize. Then in terms of another aspect of highly specialized healthcare, I also, I have already mentioned that unfortunately, a number of countries within Europe do not have access to genetic diagnostics, but also we have noticed at the very beginning that we do not have a reliable system that would ensure the high standards, so-called quality control system. And this is something that we decided to build within the Alpha-1 core group. Also in terms of harmonizing the diagnostic procedures. And we have built, we started to build the network of certified laboratories within the Alpha-1 core group. Next slide, please. And next. So the 2 core labs are Warsaw and Pavia. And next slide, please. And what we do, we actually share the samples twice a year with other European laboratories. And next slide, please. Just to ensure the harmonization and the highest quality of diagnostic, genetic diagnostic. Next slide, please. I think this is very important because that way we not only ensure the good standards, the highest standards of diagnostics, but also hopefully with the cross-care collaboration, clinical standards of clinical care. And then finally, we do collaborate in a very intense way with the Clinical Research Collaboration Network, ERCO. This is the network dedicated to science, to actually addressing the scientific goals. And in that regard, we jointly built the longitudinal European Alpha-1 registry. This is very important, not only in terms of the clinical care, as you might imagine, but also addressing the issues of the natural history of disease, comparing the data between European countries, but also ensuring the harmonization of the clinical care. In that aspect, I think ERNLung is actually the ideal setup for joining the scientific knowledge and scientific project with the highest standards of clinical care. That's one pillar. The second pillar, in my opinion, is harmonization of the standards, as I mentioned, making sure the access to highest quality healthcare provision in Europe becomes uniform. And the third pillar, very important, is the education of healthcare professional. Awareness, it has been mentioned, is not ideal as yet. And next slide, please. But above all, for ERNLung, it's very important. What is very important is the very strong involvement of patients. I am really happy to say that patients are present in the leadership of Alpha-1 core group. Patients take part also of ERCO, and I think this model is actually the optimal to provide, to meet the goals we set up for us. Thank you very much.
Thank you, Professor Chorostowska, for this quite interesting presentation. I'm certain that you'll be able to elaborate further on this during the open floor discussion. Our next speaker is Shane Fitch from Shane Fitch is an Alpha-1 parent. She is the CEO of Lovexair Foundation, and she'll be speaking about what does it mean to live with Alpha-1. Shane, the floor is yours.
Thank you very much. Could we pass to the slide? The next slide, thank you. Thank you very much for inviting me today and for these wonderful presentations. It's great to be a part of this. Well, my son was born with Alpha-1 22 years ago with cholestasis, which is a liver condition indicating that all was not functioning as normal. At that time, it was a life-threatening situation and a painful and emotional start to life, which consisted of lengthy procedures in hospitals, including a surgical intervention that in itself put his life at risk just to ensure that Alpha-1 was in fact the cause of his liver disease and to confirm his diagnosis. So from the early days, we took his health seriously and connected with specialists in Spain and other countries through a small, growing global community of patients, caregivers, healthcare professionals, and researchers, a network of dedicated people. So I made it my life's work as a parent and professionally to get involved in Alpha-1 patient advocacy on many levels to determine how we could actually do better for each person living with this rare disease. That meant learning from the very many personal difficulties people face across the world, from delayed diagnosis, as Dr. McElvaney said, 7 years on average, its impact on their lives, the limited care support, or the healthcare professionals' knowledge, to their struggle to access augmentation therapy in specific countries, or how they actually deal with the complexity of transplants just to keep on living. The rare disease movement in the early days promoted patients' right to access clinical healthcare centres and centres of excellence, which fortunately we are managing to preserve in current times. Awareness, education about Alpha-1 can guide better care practice and attention amongst healthcare professionals, as well as research, working hand in hand with patient communities, as Dr. Chorostowska has mentioned. But now we need not only to sustain these networks, but adapt and improve them in the digital era, where citizen empowerment is a key driver in a changing society. During these past 22 years, I have met alphas across the globe, listened to their stories, and often sadly have lost my mentors, friends, and colleagues along the way. So many people struggling to adapt their lives, come to terms with their condition, and even understand without genetic counseling what Alpha-1 means. Having to leave their jobs, lose their social life, suffer failed marriages or relationships, drop out of leisure or physical activities, and somehow begin their own rare disease journey. How do they manage? Often with limited care plans, little or no access to pulmonary rehab or respiratory physiotherapy, and for many are still unable to access augmentation therapy, or simply resign themselves to just stay connected to their oxygen all day long in sedentary and isolated lifestyles. Has much changed from the patient perspective? No. As demonstrated by the EARCO study published in 2020, which clearly shows that the priorities for patients remain the same as 22 years ago. Next slide, please. And now the challenges. Well, these have been addressed by all of us today. And we know that the world has changed. A pandemic has highlighted just how many of these issues can be fixed, some more simply than others. Though our new generation of alphas is still confronted by a similarly challenging scenario from 20 years ago. So how do we now address this? How do we find the alphas? We are not overcoming the barrier to identify alphas and their families in sufficient numbers to prevent potential disease onset and encourage lifestyle change and healthy behavior for those people who are at risk. So how can we go about it? There are choices. As mentioned before, we could opt for the newborn screening, or perhaps we could take a public policy approach to healthy lungs. AAT serum tests for Alpha-1 levels in children aged 1 to 2 years, when lungs are in early development, could become part of a broader public health policy, along with the vaccine schedules in primary pediatric care. This action would enable us to engage people in the early years and provide appropriate preventative guidance to parents and the right sort of education in order for children's lungs to stay healthy in general, not just for Alpha-1, but also to reduce serious infections, virus and NCDs, or exposure to the airborne contaminants, including tobacco smoking, pneumonias, bronchitis, asthma, and so on. So prevention for all people on how to keep healthy lungs is beneficial and is actually now imperative in our society, as highlighted by a pandemic, by climatic change, and by the Breathe Vision 2030 initiative. If there is an alpha issue, it can also be dealt with early on. Next slide, please. And the next. This diagram helps us to see how we can structure our connectivity in an ecosystem, a digitally interoperable environment. Diagnostic test kits delivered to our door, home care and online patient management, supported including pulmonary rehab or virtual reality. Guidance is available without overusing our hospitals or primary care in face-to-face exchange. Dedicated teams can work with us on support at scheduled times and in a convenient manner. Home-based infusion therapy for augmentation treatment has been practiced for 20 years in the USA. And it's beginning to take place in some European countries with experienced alpha advocates or practiced in communities with trained healthcare therapists. E-monitoring our patients to check on their well-being act to prevent worsening healthcare, unnecessary hospitalizations, prevention in exacerbations, can also be managed by a telehealth interface and platforms which track patients' progress in their care plans. We can get our medication reviewed or support better symptom management, and together with innovative engagement tools, even personal virtual assistants can improve our self-care techniques. And we can actually do this, ensuring that we work together in secure GDPR compliant systems. The information and data shared securely through digital platforms, interoperable EHRs and registries such as the ERN is now vital for developing a real-time knowledge about the implications of a disease which goes far beyond the lungs and the liver, enabling us to provide effective and efficient treatment and care pathways for patients, guarantee supply and safety in plasma therapies, grow registries dynamically by active use of participation, not just healthcare professionals, but patients, families, and caregivers. We can capture a broader view on Alpha-1, the natural history, including beyond the liver-lung manifestations. We can research into innovative therapies. We can improve training and education for a wider community, healthcare professionals and patients. And we can innovate in diagnostics, care delivery, therapeutics, or devices. Can you pass on to the next slide? So applying AI or relevant data science analytics to reliable and diverse data sets to calculate probabilities in predisposition to disease development, apply prevention or prediction related to disease progression, and optimize our personalized care and treatment are really just around the corner. This will in fact drive affordable, accessible, and sustainable care solutions when we achieve scalable deployment across frontiers. Shared ecosystems will enable Europeans to access these resources more equitably. So important for rare diseases because of our as yet dispersed and relatively small number of patients and expert clinical centres. The e-clinics will act as hubs together with patient communities and connect people where and when it matters. Now is our opportunity to work together with all our stakeholders, as we have been diligently doing over the last 2 decades, and embolden a Breathe Vision 2030 initiative with a call to action to make the change for alphas and rare diseases happen for the next generation. So let's work together to make treatment and care holistically available across borders in all our European countries, holding the same quality standards to fulfill the European Directive on equal rights for its citizens in quality of care, safety, protection, health, and well-being. It's time to make a difference to people's lives and show from the Alpha community just how this can be done effectively. Last slide, please. Finally, I'd like to personally pay a tribute to John Walsh, Alpha friend, mentor, and colleague, who for many years held the flag for the Alpha community worldwide from the Alpha-1 Foundation. He showed us the way through innovation, courage, and determination, and so many of us are grateful for his leadership. We are continuing on this same path. So I'd like to thank you today for the opportunity to share my experience on behalf of European Alphas, whose voices I have listened to and experiences I continue to witness over these many years, and also to my son, Aaron Strong, a young 22-year-old ZZ Alpha, a professional surfer who inspires younger generations and myself by his own example in overcoming his health issues to live his dreams no matter what. Thank you.
Thank you very much, Shane. It's really amazing to see how, or to see what you have achieved for the past several years, and I just wanted to congratulate you for this. And now I would like to give the floor to Mr. Martin Dorazil from the European Commission. Mr. Dorazil is the Deputy Head of Unit of the Digital Health European Reference Network section of DG SANTE. Mr. Dorazil will provide a short update on the European Reference Networks, especially in the context of the evaluation of the Cross-Border Healthcare Directive. Mr. Dorazil, the floor is yours.
Thank you very much, and good afternoon, everybody. First of all, I would like to thank you for the opportunity. It's my pleasure to be with you today and contribute to this very important and interesting event. So in my presentation, I will provide you with the information on the European reference networks, the latest developments, the achievements that the system has reached so far, and some future actions or the next steps that we plan to do in this area. Next slide, please. So I will start with the general kind of background of the European reference networks, what they actually are and what do they do. So the European reference networks are voluntary networks of highly specialized centers dealing with rare or low prevalence complex diseases. And they are helping the patients with rare diseases, but also they're treating health professionals through different ways. I mean, their primary area of activity is clinical. So they are organizing virtual remote consultations using dedicated teleconferencing tools, and they discuss individual patient cases and exchange clinical data in order to provide the right diagnosis and the right treatment to patients that need it. But the cooperation goes also, beyond this clinical activity. The European Reference Networks should also be focal points for knowledge generation and training and learning activities related to rare diseases. They should also facilitate the collaboration on various research projects on rare diseases, and for example, also to the development of clinical practice guidelines. The underlying principle of these networks is that for rare diseases, it is very difficult for individual member states to have all the expertise they need due to the rarity of those conditions and the expertise being scattered in different centers. So these networks are trying to pool the expertise and knowledge and make it available for the large rare disease community. Next slide, please. With regard to the formal, framework that we have for the European reference networks, they are based on the directive on patients' rights in cross-border healthcare that was adopted 10 years ago in 2011. And this directive currently is undergoing an evaluation. So it is being assessed whether the legal provisions and the underlying policy is still fit for purpose, or whether there are needs for adjustments of the legal framework. And I will speak about it a little bit later in my presentation. Next slide, please. What has been achieved so far is that on the basis of the Cross-Border Healthcare Directive, we actually supported the establishment of individual networks in 24 different areas, specializing in different rare conditions. This is just a list, just for your information, of the existing 24 European reference networks. The ERNLung, dealing with rare respiratory diseases, including Alpha-1, was mentioned already, so I just want to highlight this one. But I mean, we, as you see, currently we have 24 networks. Next slide, please. And on this slide, I just try to summarize the main achievements and the main areas of activities of the network so far. So as I said, the networks were set up in 2017. Currently, we have more than 900 highly specialized healthcare units being part of the system, coming from more than 300 hospitals all over Europe. And we are also currently undergoing a process of geographical enlargement of the networks. So there was a call for new members to join the existing networks, published recently, and currently we are assessing the applications for these new members, and we expect the system to almost double its size. So far, we have managed to have a clear legal basis in place. The 24 networks started their clinical work. We have a strong political support at the EU level, and the RNs are really perceived as a very good example of European cooperation. And what is very specific and unique about the project is that is the joint ownership. So there is really a combination of different stakeholders that are making an effort in the same direction. So obviously, member states authorities, need to be supportive of the initiatives of the ERNs, but we have also strong involvement of patient representatives. For example, in the governance of each network, there is a representative of patient organization. Clearly, the whole project is driven by health professionals and their enthusiasm and their initiative to network and work together across borders. We also have strong support from the hospital managers and healthcare providers, and obviously also the EU institutions, in particular the European Commission and also the European Parliament. We have secured funding from the available EU instruments. So just recently, at the end of March, the new EU for Health program was adopted, which provides a financial framework for the period from 2021 until 2027, so a multi-annual framework. And the European reference networks are mentioned as one of the specific objectives to be supported from this program. So there is funding available for the coordination of the activities at the European level. This does not mean that this funding is sufficient, because we also need the member states, to play their part in the project and support the healthcare providers and professionals at the national level. And we have a consolidated governance and solid networking structure in place. With regard to the specific actions I mentioned already, most of them, so clinical cooperation on patient cases via the telemedicine tools, knowledge generation, in particular, in the area of training, education, and awareness actions, development and implementation of clinical practice guidelines. The networks are already publishing, an important number of scientific publications. They are engaged in various research projects, and we are supporting also development of patient registries for each network that should in the future become part of the future European health data space. Next slide, please. I think we can go to the next slide because this is just more details about the enlargement. This is a snapshot from our website where you see, the geographical coverage of the European reference networks, and almost the whole area of European Union is already covered by either the full ER members or at least affiliated partners. The next slide, please. So with regard to the next steps, I think, and I try to structure them in 5 main areas. So very briefly, one upcoming challenge is to manage the current enlargement of the geographical scope of the network. So we need to complete the ongoing enlargement, and we need to consolidate the whole system and ensure long-term sustainability, both financially. So I mentioned already the EU4 Health program, which is an important instrument, but we will also need member states engagement and also the organizational structure of the networks, because this will be quite challenging, especially on the coordinating centers now, if the networks substantially increase in their size. Next slide, please. So the other area of action is the integration of the European reference networks into the national healthcare systems. It is very important that the activities taking place at the European level and the cooperation at the European level are then transformed also to the national level, and that there is a clear there are clear pathways and clear referral procedures for patients, at the regional, local level, and their health professionals, that they are aware of what the ERNs can offer, and that there is a clear system for referring patients, so that they can benefit from the activities of the ERNs as much as possible. And we intend to support the efforts of the member states in this area by joint action, so by providing funding, possibly not for 2021. I mean, there is a question mark, but it's more likely to be in 2022. But it's an important area we need to focus on. Next slide, please. The third area clearly is the knowledge generation, and that's where the European reference networks can play a very important role. So we are supporting the networks in development of the clinical practice guidelines. We plan to set up in the near future the ERN Virtual Academy, so a platform for online trainings for health professionals dealing with rare diseases, but also, for example, for patient or patient representatives. We are organizing a professional mobility program so that the health professionals can spend some time in another specialized center within the same network and learn from their colleagues in the other center. And the networks are also preparing their training and education strategy. Next slide, please. Obviously, research on rare diseases is a very important area where ERNs can provide significant added value. So as I mentioned, we are supporting all 24 networks in a setup of their patient registries. And we need to make sure that these registries are linked with the future European data space. And next slide, please. Last, but certainly not least, we also need to start demonstrating the added value of the ERNs. They were established, 4 years ago in 2017. But now we are coming to the stage where we need to evaluate, how they work, and perhaps make some proposals or recommendations for future improvements. So there are 2 important initiatives ongoing. I mean, the first one is the evaluation of the Cross-Border Healthcare Directive, which I mentioned previously. which is an evaluation of the general policy and the legal framework that should be completed next year, and where involvement and contribution from all the stakeholders will be very important. So I just would like to encourage you to contribute to this. For example, we are planning to launch an open public consultation in May, so next month, that will be published on our website. And a very specific part of the consultation will also deal with the issues related to the European reference networks and rare diseases. So you may wish to contribute to that consultation in that context. And another important initiative is the first periodic 5-year assessment of the performance of the networks and their members that will start 5 years after their establishment in 2022. And we expect to have the final report available in 2023. Next slide, please. And I'm coming towards the end of my presentation. So just, to provide a little bit more details on the ongoing evaluation that I just mentioned. Here are some questions, some evaluation questions that we are trying to answer, as part of this evaluation of the Cross-Border Healthcare Directive. So how effective is the directive in supporting the diagnosis and treatment of patients with rare and complex diseases through the European reference networks? How effective is the knowledge sharing among the healthcare professionals thanks to the ERNs? What has been the impact on ERNs on research on rare and low prevalence and complex diseases? Whether the ERNs as set out in the directive are still relevant for meeting the needs of patients with rare and complex diseases, or in what ways the ERNs established by the directive provide an added value for patients in comparison to purely national solutions. So this is what the evaluation will try to establish, and on that this will help us then to conclude what actions to take in the future and how to adjust the current system. With that, I will conclude my presentation. Thank you very much for your attention, and I wish you good luck for the rest of the event. Thank you.
Thank you very much, Mr. Dorazil. And now we will move into the open floor discussion. I think we still have a couple of minutes to address some of the questions which were tabled. If you do think about additional questions, please make sure to type them either in the chat or the Q&A box. So the first question I have here is to Professor Chorostowska. To what extent the ERNLung and other EU-based structures involve patients, patient organizations to identify and solve their unmet need?
Well, as I mentioned, patients are an important part of the network. Patients are members of the core groups. Patients are also involved in the leadership within the groups. So I do believe that the patient's voice is very strong within the ERNLung, and this is a very important, and I would say very fundamental issue. However, I think it was hopefully clear from my presentation, but also Mr. Dorazil you have shown the map, the latest map following the latest call for new members of ERN networks. And if you look at the map, it's pretty clear that there are regions within Europe of unmet needs. So density of centers is definitely more to the Central Western Europe. And then if you look eastwards and westwards, the density is not as good as we would like to have it. And I think that speaks for the unmet need of the patients, first of all, unmet need of diagnostics and clinical care. And also, if one looks at the numbers of diagnosed patients in, let's say, my region, Central East, clear that we definitely are not as efficient as we should be in terms of providing diagnostic and clinical service to the potential patients, because many of them have not been diagnosed. And secondly, it also speaks for the fact that the potential expert centers, the centers that could potentially develop into the centers with the highest expertise, need probably some help, either from the network or from the EU or from the local governments. This is for me, a very open question, probably a very individual question. Nevertheless, we definitely should consider some kind of support or stimuli that would really prompt development of supporting centers, collaborating centers, that would become an expert centers in those regions of unmet need. And I think that very well links the patient's needs, but also the potential, very high potential I do see within the ERN networks. Thank you.
Thank you very much, Professor Chorostowska. The next question I have here on the list is to Professor McElvaney. It is from Frank Willison from Alpha-1 Plus. Is there any research going on to densify lung tissue and to bring a lung with emphysema back to a normal lung? What is your perspective on that?
This is a really interesting question. Unfortunately, the lung is a very fragile organ, so it doesn't heal well when faced with an inflammation. So it heals by scarring, basically. So unfortunately, we have looked at attempts to see if could we regrow lung or revitalize lung. And all the attempts to date have been, unfortunately, ineffective. There's no evidence that we can regrow normal lung. So that's one of the problems with emphysema. Once you've got it, it's very hard to, it's impossible at the moment to regress it. You can either stop it progressing, but actually restoring the lung to normal is basically impossible with what we have at the moment.
Thank you very much, Professor McElvaney. The next question is again from Frank to Professor Chorostowska. Frank writes, Alpha-1 antitrypsin deficiency is a rare condition treated by augmentation therapy in only 17 out of 47 European countries. Do you think ERNLung and YARCO activities, like your Cross-Border Healthcare Initiative, will flatten these conditions so alphas can get augmentation therapy more easily in a neighboring country in the next 10 years?
Well, this is what I call a tricky question. I would love to say yes. So, of course, the access to treatment very much depends on the local policy of the government, of the reimbursement policy. This is not up to ERNLung, neither to clinical research network. However, we could also play an important part in changing this situation by, for example, making sure that diagnostic is accessible in those countries. So we would be able to diagnose patients, we would be able to provide them with the accessible clinical care, with the expertise, and then hopefully this would prompt the regulators, the local national regulators, to consider reimbursement for accessible for existing treatment. And it is, in my opinion, important also because I think that would provide the ideal setting for this highly specialized treatment. So we would actually create an environment, highly specialized, the medical, clinical environment for providing the highly specialized treatment. I think that would be the optimal setup. Therefore, yes, the answer is yes, but conditionally.
Thank you very much, Professor Chorostowska. And we have one more question to you. To what extent, how do disparities in access to specialized care affect Alpha-1 antitrypsin deficiency patients?
Well, they definitely do, and I can speak for that. Being part of the Central Eastern European Alpha-1 network, significant number of countries in my region do not have access to neither treatment, that includes Poland, but also to diagnostics. And in that regard, disparities definitely affect patients in in many possible ways. In terms of, but also in terms, I think, in terms of education and social awareness, public awareness of the disease, that also is affected by the disparities. So, in conclusion, there is much to be done And there's much to be done both by European Union, healthcare professionals, but also patient organizations. Thank you.
Thank you very much, Professor Chorostowska. And I think we have only one more question, but I don't think we have time to respond it now. So this will be responded to in the subsequent report from the event. And now it's time to move to the conclusion. To the conclusion of the open floor. I wanted to thank everyone who participated in the Q&A session, and especially our esteemed speakers. And now I just want to pass the floor to Ms. Wiseler-Lima and Ms. Matias for the concluding remarks. Perhaps Ms. Wiseler-Lima first.
First of all, I really want to thank all the panelists for this really high-level contributions. It was very interesting to listen to you. From a political point of view, I was really very convinced that what Martin Dorazil told us, I hope I said the name correctly, told us, and I think it's very promising what all the analyses that are done, and the way we want to go. I think this can really help patients. Now what is really important is the implementation. Often that's the problem, and I had written member states right 2 seconds before Mr. Martin Dorazil named the member states. So I really think that it has to be done at all levels. I will stop here. Thank you very, very much. It was very interesting, and I'm very confident when I see how many energy all of you put into this. I'm confident. Thank you very, very much.
Thank you also from my side. I want to thank all the presentations, to say it was really interesting, and I've learned a lot, and of course it just reinforced our intentions to support, to back your demands and the ways you are trying to improve people's lives in such a way like you have presented. I want to say also that it's quite clear after this seminar that we really need to engage and to involve patients and experts and those who are used to get involved with the patients through the research and through the clinical methods. So again, I want to thank you all very, very much. And I would just say that, yeah, it's quite promising what was presented by the Commission side. I think that we are moving forward. But again, I think it will be even better if patients and experts are engaged and involved in all the phases, not only in the implementation, but also in the design, in the conception, in the way things are defined in order to be implemented after. So thank you so much again, all of you, and we'll keep in touch for sure. Thank you.
Thank you very much.
Thank you very
And
much.
with this, we conclude. Thank you.
Thank you very much.